So our next speaker is Dr. Hyman Scott. He's an assistant clinical professor of medicine and clinical research and medical director of Bridge HIV San Francisco Department of Health. So Dr. Scott is going to talk about shots, updates on oral and injectable pre-exposure prophylaxis. And we've already pepper him with a couple of questions here that we can come on up and we can end with that. As soon as you want to begin.
I can actually address these. Great. Good morning, or good afternoon. It's still morning in California. So I'm going to talk about PrEP, which is one of my favorite topics. So I have no financial disclosures, and there's several cases that are also peppered through this talk, so hopefully we'll stimulate some interesting conversation. So I'll talk about the efficacy of the available PrEP options that we have, initiation, monitoring, and discontinuing injectable PrEP, and then some of the management issues that come up with our PrEP patients who have discrepant HIV test results. And so I think there's been some interesting data that's been presented in the last year around some of the testing, particularly for CAB-LA, that I think is going to make our lives easier, not harder. I think the viral load requirements were a pain, and hopefully we can sort of shift away from those. So the CDC actually told us to stop using their estimates for to stop using their estimates for PrEP uptake because they're wrong. And so I think that they got some feedback around some of the disparities that they had been documenting, which really showed that essentially white MSM in the United States were up at upwards of 90% coverage for PrEP. Overall, I think our experience is that PrEP coverage has been in the 20s or 30s overall. There's been some important and persistent racial ethnic disparities as well as gender disparities among cisgender women as well as trans individuals. And we also have regional disparities in where PrEP coverage is. So the darker colors, is more coverage. You can see that it's really highlighted in the major metropolitan areas, and that we really have some gaps, particularly in the U.S. South. So lots of work for all of us to do for PrEP coverage, and I'm excited that I think Ryan White as a program is the structural intervention that has really changed the trajectory of HIV in the United States, and we need a similar program to really cover PrEP and close these gaps. And there was an interesting presentation at CROI this summer, in the spring, which showed how PrEP coverage relates to HIV diagnoses at the state level, and that overall that PrEP coverage was low across all the states and ranged from about 5.8% to 15.7%. So that's the highest coverage was about 15%. But in those states that had the highest coverage, they saw 8% decline in in HIV diagnoses. So it really shows that even a small improvement in our PrEP coverage can have a big impact on our HIV diagnoses. And when there was really no change in PrEP coverage, that there wasn't a change in HIV diagnoses. So, I think the data is really from international studies, but also locally, that, we are not going to be able to treat our way out of the epidemic, that we really have to incorporate PrEP and we have to be aggressive in our outreach and efforts. So I'm going to start with a case around PrEP start. So this is a trans woman who's interested in PrEP. She's on injectable estradiol for gender-forming hormone therapy. She has gluteal fillers, which was a gender-forming procedure that she had in Mexico. And she has researched PrEP, and she wants to use on-demand if it's possible. She has receptive and insertive anal sex with cisgender men and transgender men, and has insertive vaginal sex with cisgender women. So what options would you offer her? So wait to get to about more than 100. Okay, there we go. It's picking up now. All right. So I think 150 will be our magic number. Thank you. All right, so any of the above options, and I'll talk through some of those, and I think that's absolutely the right answer. So it is whatever she wants. And we'll talk about some of the considerations given some of the demographics, the fillers, on demand, and some of the sexual activity that she was reporting. So thankfully, as many of you might remember, when PrEP was first approved, there was actually a contract that all of our patients were asked to sign that essentially said that they would risk mitigate and that they would use condoms. Thankfully, that has gone out the door, and now we sort of have moved from a risk-based to a sort of more universal offer and education of PrEP. So the current CDC guidance is that if someone wants PrEP, they should get PrEP. And there are different options that are available. I think of oral TDF-FTC as the PrEP for everyone, and that it can cover anyone who is interested in prevention in the absence of any renal dysfunction. And there are some considerations for TAF-FTC, 211, and CAB-LA. CAB-LA has not been studied for people who inject drugs, and 211 has been most studied in cisgender men. There were a few trans women in the studies in Europe, but it is something that we offer. And I'll talk a little bit about some of the considerations for gender-forming hormone therapy, which is one of the sort of considerations for using it with trans women in particular. So these are the IAS-USA recommendations for PrEP by population and by transmission risk behavior. And you can see that there is some data missing. There's some data gaps that we have, and hopefully we'll be getting some more data on this. 211 is never going to be approved by the FDA, so this is all off-label use. There is, I think Gilead now is moving away from our advancing access, and thankfully there's been a lot of community outcry around that, so it's going to really curtail some of the access our patients have. But it's not going to be submitted, so it's something that we use our data for. And then for this particular patient who's having insertive and receptive sex, anal sex and vaginal sex, they have all the options available. And then receptive vaginal sex, there's insufficient data reported. I'll talk a little bit about some of the data that we do have around 211 for this patient, as well as oral TAF-FTC. So I think, as I was said earlier, the best PrEP regimen is the one that person will use, and thankfully now we have more and more options and really provide this through shared decision making. I think some of the data we're also seeing is that efficacy is not the primary reason why someone will take PrEP. It's really about convenience. It's about what is in their best, fits in best with their lives, and we really should center that in terms of our decisions about what PrEP is offering for people and giving them the option to make a choice. I think one of the choices that people are making is CAB-LA, and that's a journey for us all because it is such a challenging implementation for CAB-LA. So this is some data that was presented HIV R4P this fall that really talked about how practices can prepare to initiate and continue our patients on CAB-LA, and really talked about some of the most successful solutions and strategies for CAB-LA integration. I'll talk a little bit about this in the breakout session, but really about task shifting, ensuring your clinicians are comfortable with injections, creating flexibility in the schedules so that patients can stay on schedule, making sure that there's interest from the staff, because this is going to be additional burdensome. It's moving the adherence from the patient to us. And so that's going to fall on most of our staff. And then, there's a variety of tools that you can use. So I'll talk a little bit more about this, but this is a pillar study, which was a V-funded study, but really highlighted some of the strategies that seem to work in clinics around the country and sort of implementation of CAB-LA. And one of the things that has been striking from this discussion of choice is that we really haven't had any data to say that this actually makes a difference. We have a lot of data from the contraceptive literature, which has really the sort of parallel sexual health field that shows that when you increase number of options for contraception, you get about 5% increase in uptake. But that changed at CROI, where they presented the search dynamic choice prevention intervention. And this was giving people a choice of what PrEP options they wanted, but also is not just about the drug. It was about giving support. It was about helping individuals navigate other challenges they might have and giving them access to someone who can talk to them about their concerns about side effects. And what they saw is that when they offered this as a choice, and Cab-LA was not offered as part of standard of care in those communities, that more than half chose Cab-LA, which I think was very interesting. But if you also look at what happened with oral PrEP, that actually went up significantly as well. It was more than double the use of oral PrEP, and that almost a third, 30% of people used multiple options. And so really that highlighting that giving people choice does make a difference in getting overall uptake and coverage. And when they did this, they saw that there was about 70% coverage of sexual risk. There's prevention coverage compared to about 13% in the standard of care, and that this was the same across the groups. And in particular in these communities, I think young people and cisgender men were difficult to engage in PrEP activities, and they were able to use this choice intervention to support them getting access and staying on PrEP. And that over half chose Cab-LA when it was offered, and many of those people actually hadn't been on PrEP in the prior month. So this really is reaching those who we want to reach. It's expanding the pie, and this was, they saw no HIV infections. And so I think that this was really telling that with this level of coverage of 70%, we might be able to eliminate HIV incidents in many of our communities versus the standard of care, which was close to 2%. So I think this is something that we're evaluating in a few other studies with adolescents and among Latino MSM in the US and South America to see if there is, we can develop additional data around how choice impacts what we can achieve from a prevention standpoint. Drug-drug interactions with GAT, there's a lot of controversy around this. There's a lot of community concerns around the impact of PrEP on gender-forming hormone therapy, and there is some evidence that there's a slight reduction in tenofovir levels with estrogens. However, that is no different. It's within the range you get within fasting and fed states. So what I tell my patients who are on gender-forming hormone therapy is just take it with a meal if you can, and taking 211 with the meal is what I recommend as well. So I just provide counseling. I don't restrict it if it's what somebody wants, because we have emerging evidence that if you give people what they want, they're more likely to stay on it. Gluteal implants are a big question around Cab-LA. We actually have done some studies as well. We have within our communities, trans women who have a variety of implants from silicone and other types of implants. And even with the presence of implants, we're still able to safely provide Cab-LA. So we just examine the area, try to identify a location where we can safely give the injection. And then we will sometimes consider imaging with CT ultrasound if we're unsure. And that's actually been quite helpful in identifying places where we can safely give the injections. I think from a patient perspective, the sort of engagement and extra work to identify if this is something that they can receive really helps to retain them into care as well. And there's some data around alternative injection sites. ViiV has done a couple of phase 1 trials of thigh injections. The PK does look comparable to what you would get with gluteal injections. Injection site reactions were very common. They happened in everyone. So this is something that will likely hurt more than our current gluteal injections, but hopefully will be an option that we can provide for people who might have gluteal injections that prevent them from using one of these injectable options. So my key takeaway of this is choice matters, that we really should focus our center our clients' preferences in what they want and try to work to provide that to them, and that on-demand PrEP is an option for individuals who are on gender-forming hormone therapy, and that gluteal implants and fillers are consideration, not an exclusion for Cab-LA. I didn't want to leave without talking about lenacapavir. This is exciting data. These are the tree of the PURPOSE studies. So PURPOSE 1 was focused on cisgender women in Southern Africa. PURPOSE 2 was among cisgender cisgender gay men, bisexual men, and gender diverse individuals in the Americas. And there's some smaller bridging studies among cisgender women in the US, people who inject drugs in the US, and some small studies in France and the UK. So Purpose 1 among cisgender women was one of the first trials that's starting to encounter this challenge of it is no longer ethical to conduct these studies with a placebo arm. So you have to have an active arm, and how do you assess incidence if you have low incidence in the active control? So in the Purpose studies, they use this cross-sectional incidence cohort. So anyone who enrolled in the study had to have HIV testing with them. And then if they were HIV negative, they got randomized to receive one of the study products, which was lenacapavir, TAF-FTC in Purpose 1, or FTDF. And this was to get more data on FTAF because we have an FDA label that excludes individuals who have interceptive vaginal sex. And these data were presented, and this was the first clinical trial PrEP that showed 100% prevention efficacy. I think this was exciting, and it was unexpected, and I think it really reflected the potential of this intervention. What you can see, though, is that FTAF and FTDF were not different from what they saw in the background. And so I think it really reflected that adherence was driving this. So they did a matched control analysis to look at FTAF to see if individuals were taking and had adherence, medium or high, did it reduce HIV acquisition risk? And the answer to that was yes. And so there was a lower odds of about 89% compared to individuals who had low or no adherence. So this is actually data that Gilead is using to move forward to try to expand the indication for FTAF, so it can be an option. But I think it also reflects if people don't take the meds, they don't work. I also appreciated that what they did in Purpose 1 was allowed the women who became pregnant in this study to make a choice about whether or not they wanted to continue receiving the study product. We run in circles after we have an approval because we have no data among pregnant individuals. So I think that all of our prevention studies, hopefully, and some of our treatment studies will continue this effort. And what they found is that individuals who became pregnant did want to continue in the study, and now we have data that shows that this is likely safe that we can use and continue during pregnancy. And so we have this paucity of data around the use of PrEP in pregnancy, and I think some of these study designs will allow us to get those data to make those decisions. So for Purpose 2, which is the sibling study, I guess, for Purpose 1, did not use FTAF because we already have an indication. Similar study design, and then it was comparing it to FTDF as an active control. And these data were presented at R4P by Colleen Kelly, and they saw 2 infections. So again, they saw a background HIV incidence of over 2%, and then a FTDF incidence of about 1%, which is similar to what we've seen in our other trials. And there were 2 infections in the LEN group. There were some data presented at Glasgow, I think last week, around what these 2 infections were. Both of them, one was a cisgender man, one was a transgender woman. Both of them had what sounds like acute HIV at the time of diagnosis. When they looked back at stored samples, there was no evidence of sort of this smoldering infection like we saw with CAB-LA. And they both had levels that were consistent with what we think should be protective. So this sort of happened in the setting of therapeutic levels. And both of them had resistance to lenacapavir. And so I think that we're going to get more data as the paper is published, but it does seem like there is a potential for failure like we've seen with other injectables, but we're not really seeing the Levi syndrome, which I think we were worried about would be the case for all injectables. But I think that how these are functioning is a little bit different, and we're not sure exactly how this will play out once we roll this out more broadly. So for Purpose 1, the adherence data, as I mentioned, was here. So adherence to orals was really not that great, but similar to what we've seen in other trials. And then the injections, of course, were high adherence. So that's what was driving the efficacy. Injection site reactions for lenacapavir, if you all are using it in your clinic, are high. And these are nodules that occur, and the best expression I've heard is that this is a feature, not a bug, of this of this product, and they happen in the majority of participants. There are more participants who discontinue lenacapavir in Purpose 2 compared to Purpose 1, and some of these nodules, we were one of the study sites, are quite big. The needles that are used for the subcutaneous injections are also quite big. They're 23 gauges. One clinical site has something they call the scream room where they administer this medication. So, I think that it's going to play out in how we roll this out. And so it's going to be important as we sort of counsel patients about this, if they choose this, around the injection site reactions and what can happen. I think some of our participants were quite shocked at the size of the nodules that occurred. So I think a lot of anticipatory guidance is going to be needed as we roll this out. And I say this now before we're having access to this, because I think how we started is going to matter significantly, and that we want to really counsel our patients so that they know what to expect. So key takeaways: this is an exciting new option for prevention. We're going to get more data on the failures, and then really thinking about these injection site reactions for the nodules. So this is a case of comorbidities. So this is a 47-year-old with hypertension, diabetes, and hyperlipidemia, creatinine clearance of 89. He has been on TDF-FTC PrEP before and stopped 2 years ago. And he's interested in the safer version, but he's concerned about ARVs causing weight gain. What would you offer him? So it looks like daily TDF-FTC or on-demand TDF-FTC. All right. So this is a slide I'm sure you've seen multiple times. This is a really good sort of diagram. We actually use this in our counseling. It sort of compares FTAF to FTDF and some of the differences between them, really visually, to help people understand what the differences are. There are some data in JAMA that show there's an increase of hyperlipidemia risk with TAF-FTC, as well as hypertension risk. And so those are some things that I counsel my patients on as they're making a decision about which PrEP option that they're interested in with comorbidities. And then there was some data presented in CROI around HPTN 083, where there's this question of hypertension risk. So it did not appear to occur in the setting of CAB-LA use, but weight gain does. And so this is something that I talked to folks about, that there was about a 1.2 kg increase in the CAB arm compared to about a 0.3 in the TDF FTC arm in HPTN 083. So, weight gain is a concern. And there was some data from HPTN 077, which was the phase 2 study before the HPTN 083 study, which did not show weight gain, but in this larger clinical trial we did. So we really try to give people that guidance when they're making a decision. So discordant HIV test results. So this is a 31-year-old who comes in for routine tests, and his fourth gen comes back positive. Confirmatory is negative. So do you repeat the tests and continue PrEP, and just assume it's a false positive? Repeat the tests and stop PrEP, but start ART for acute HIV infection. Repeat the tests and stop PrEP until you can determine what the infection is, and just leave them off any prevention, or do something else. So 40% would repeat the tests, stop PrEP, and start ART for acute HIV infection. So I think that, Carolyn showed this, just sort of the what happens with the viral load and the HIV testing, and we see a lot of discordant tests. I think this drives us a bit crazy because we're concerned about acquiring HIV. I generally do exactly what the audience, almost the majority of the audience said. This actually occurred with one of my patients who's on a PrEP for a serodiscordant relationship. And her partner was virally suppressed for 5 years. She said that that was her only partner, but we started her on Biktarvy, or bictegravir, TAF, in order to, while we were waiting for the repeat testing. Given the side effects of the current regimens, really little reason to hold that. Within HIV testing and long-acting PrEP, this is actually one of the questions on the cards. There's been a lot of guidance around using viral loads, and the data from HPTN 083 suggests that a viral load is not necessary, that these were some data that show that the positive predictive value was 100% if you had a rapid test and antibody antigen tests were positive for diagnosing HIV with CAB-LA. So I think for a lot of sites that are interested in offering this but have limitations to viral load testing, that this has limited the ability to implement this. And so we're still waiting on data from lenacapavir on the impact of that on HIV testing. But I think that this gives us some reassurance that if you can't do viral load testing, that you can still make a diagnosis with lab-based testing and repeating testing. So these are some of the strategies that we think about for how you interpret these tests. So you can continue PrEP and have the risk of resistance. You can stop PrEP but have risk of HIV acquisition. You can start ART, which may make the confirmation of the diagnosis more difficult. I generally lean towards starting ART, particularly if there's any breaks in adherence, and there's always the PrEP line that Carolyn talked about as a great resource for us. There's also the National HIV PrEP Curriculum, which Carolyn mentioned, which is a great tool to walk through some of these cases and to sort of talk through and walk through some of the strategies for management of PrEP. So I'm going to end with some CAB-LA discussions. So this is a 42-year-old MSM experiencing homelessness who uses meth and engages in sex work. He's having trouble with oral PrEP, and his meds were stolen, and he can't remember to take the pills when he does have them. He started PrEP with CAB-LA and had some mild injection site reactions, but he missed his second initiation dose, and they couldn't find him. So he drops in the clinic 2 months later and is interested in getting those shots that he got last time. So what would you do? Would you just administer the CAB-LA while waiting for the 4th gen and viral load? Would you get a rapid test, and if negative, administer the CAB-LA while waiting for the lab testing? Would you send the 4th gen viral load, wait for them to come back before giving them a shot? Or would you send the 4th gen and viral load, wait for it to come back, and if negative, give the CAB-LA? Actually, those are C and D are the same, actually. So both are an option. I don't want to say if they're right or wrong. There's no wrong answer. All right, so folks have rapid test access. So the majority would get a rapid test. If negative, administer the CAB-LA while waiting for the 4th gen HIV test and viral load. So I think that this is someone who is coming back 2 months afterwards. So they have had an injection within the last 6 months. The rapid test is already going to have a lower sensitivity than the 4th gen, so you anticipate that will likely be negative. So in our clinic, we don't always do the rapid test for that reason, but I think if you have access to it, it's worth just getting that test and then administering it. I wouldn't delay it. This is someone who's coming in. If they if you can get the blood draw, I think it's the right thing to do, to just give them the CAB-LA, wait for the test to come back. If he comes back in a few days, you can start them on ART if they have an unrecognized HIV infection. But you have, if they're negative, then you've actually connected them back into the clinic and to the care. So I think that would be the right answer. So the FDA label is really about covering missed doses, and they make this distinction between planned and unplanned, which I think is arbitrary. If it's late, it's late. If it's not, it's not. And so generally, I take the approach as if it's beyond 12 weeks since their last injection, then they need a reload. If it's less than that, then they can just have a late injection without having to get reloaded. And we have a lot of this data from 083 around delayed detection, which is why we've been using the viral load tests. I think I had some conversations with folks earlier. What we do at our clinic is we give the injection, draw the blood, and then wait for the results to come back. We don't force a second visit before and review those results, so that if someone has HIV, we're going to know it within a few days, and we can get them back in and get them started on ART. But it's a challenge already with the volume of visits, so if you double the number of visits, you're going to make that much more difficult implementation. We are seeing INSTI resistance in failures when people are receiving CAB within the last 6 months. So that's really the scenario where you get concerned about potential INSTI resistance given the long tail. But anything beyond that, you're unlikely to have a resistance. We talked a little bit about Levi syndrome, and it's essentially this smoldering infection. Seems like it might be specific for CAB-LA and not for all long-acting injectables, so we'll see if we have more data from lenacapavir as we roll that out. But essentially it's just smoldering, low-level infection without the acute HIV symptoms. And this is a comment about seroprep, which Carolyn mentioned, which is an opportunity for us to do testing, more single-copy testing if someone is a failed test. There was a report that was recently published of a first clinical failure of CAB-LA with on-time injections. This was actually the group that did the additional testing. It was an individual in Chicago who was getting on-time injections and was diagnosed with HIV. Interesting in that case, a lot of the challenges that they had were actually insurance. So we talked a little bit about how the insurance is a mess for this rollout, and I think it's impacting our ability to get this out to people. So in summary, I think PrEP is for everyone who wants it, and we really should consider some of the comorbidities, but minimal reasons not to offer one of the options for PrEP as we get more and more PrEP options on our menu. Missed CAB injections are going to happen. I think some of the clinical implementation and structures that we can create to make it easier for our patients to come in and anticipate them by giving them options for bridging. There was a question about PEP in pocket, and I actually think that's something that I'm going to start working with our clinic on implementing. I think that we are underutilizing PEP, and we have great options now with minimal side effects. So we'll still, I think, learn a lot about how we detect HIV infections with delayed long-acting injectables. And I would like to thank all of my collaborators and happy to answer any questions that you all have about PrEP.
Great. Wonderful
Mike
review.
has a stack
Got a whole
of
bunch
questions.
of questions here. So testing before each injection of CAB, do you do that? Do you do antibody, viral load? How do you manage that?
Yeah, so what we do is we schedule the visits, and then we have them come in, get a blood draw, do HIV antibody antigen testing, viral loads, give the injections, and then Usually our antibody antigen tests come back several hours later, and the viral load comes back a couple of days later. But we don't do rapid testing, and we don't require them to come in and get the testing. Our team initially was sort of wanting to do these extra visits, and they wanted to make sure that they had an appropriate bridge, and I said that's a bridge to nowhere, except to keeping and making more challenges for our patients. So we try to minimize as many visits as possible.
211, can you talk a little bit more about it? Who might you recommend that for, and how is it implemented?
So 211 has been studied in MS, cisgender men who have sex with men, and a small number of trans women in the studies, and it was primarily been done in Europe, so France, and then parts of French-speaking Canada. And the data suggests that we have about a 91% efficacy in HIV prevention, which is similar to what we saw with the PrEP clinical trials. So in my opinion, 211, for those who can use it, is equivalent to daily oral PrEP. And so we offer it to everyone in an even-handed way and say, if you are a cisgender man or trans woman or have sex with men, you can use daily or on demand. And about 20% of our patients in our clinic decide to take 211, oftentimes going back and forth because we give them enough so that they can take daily, because 211 becomes 21111 if you're having a lot of sex. And so we don't want people to have gaps in their coverage. And so we will just give them enough to take daily, so they end up going back and forth depending on what's going on with them.
Right. I found it mostly useful for people who are not having high frequency of exposures.
So we've actually moved away from that sort of projection about what we think someone might want, and just say, this is an option
Here
for
it
you,
is.
and you can decide what it is that works best for you. And they might say that they start 211 and just continue daily. But I think ultimately when we looked at our data, it was the individuals who had fewer sexual encounters. But that wasn't always the case. There were episodes in Pride and Folsom, and a lot of the street fairs we have in San Francisco where daily use was being used.
All right, so the difference between HIV NAT and HIV RNA?
Yeah, so the HIV NAT testing is actually an FDA-approved testing. It's sort of like what we do with our STI testing, where you sort of get a positive or negative. And so that's actually an FDA-approved HIV screening tool. And then the RNA is the individual copies that you see, like less than 20 or a number. And so generally the labs, we don't use NAT testing. We use the individual viral load testing for most of our tests.
How big are the nodules with lenacapavir, and would it help to give lidocaine ahead of time before the injection?
Yeah, so they can be big. So we had, I'll use anecdotes because we haven't seen like a lot of pictures. So we had a participant who had a nodule like that big.
Yeah.
And it was like red. It was probably like 7 centimeters on his. So lenacapavir, if you've administered, is 2 subcutaneous injections in the abdomen. It's every 6 months. And so they can also be quite red. I think our experience has been that if someone is relatively trim and has low body fat, that's really where you will have more of a visible reaction. The nodules will be just closer to the skin. I think there's probably a higher risk of having it more subdermal than subcutaneous. So you might get this reaction that occurs. So I think that was our experience, that the individuals who seemed to experience the most uncomfortable nodules were those who were sort of on the thinner side, and they lasted 8 weeks.
Yeah.
So it's pretty. And I shared this. I'm a little concerned that if this rolls out, this is going to happen, and someone's going to post it on Instagram, and then this is going to be the reputation that it has. So I think it's really important that we communicate with our participants and our patients about like what can happen, so they're not surprised and shocked.
Yeah, I hadn't used much of it, but I was out actually at San Francisco General about 3 or 4 weeks ago, and up on Ward 86 around the corner, there's the injection center, and the nurse practitioner there, I said, so how real is this? And he went, oh, it's real, we see it, but it can be managed. But I'm a little surprised that with the release of all the PROMISE 1 and 2 studies that there's no mention of it whatsoever, and it's got to be real to some degree.
Yeah, I think that what we're going to see is that once we start rolling this out, this is industry-sponsored study, so we want to be mindful about what we report. I've had some conversations already with, with Gilead, but also with advocates who are like not also hearing about this stuff, and I think we need to be ready for what happens when this rolls out, and I think this is a potential threat to some of we're going to get one chance to roll this out, right? Yep. And I think we want to be upfront and open and clear about what can happen so that people aren't like freaked out when this happens.
Right. This is a follow-up about the 211 and folks having inserted vaginal or front hole sex. So was it only MSM being studied for the original studies?
Yeah, so it was MSM and trans women. So it really was focused on receptive anal sex. I think that's where we have data that the PK suggests that the levels get high enough in the rectal tissue versus the vaginal tissue. I mean, I think I'm putting less emphasis on some of those PK data because I think if we did that, then CAB-LA should have never worked, and it's not clear how LEN would work. So I think having the clinical data that this worked with those groups. We don't have the data with cisgender women, and so I think we've had so many trials of PrEP with cisgender women that just didn't work at all, that I think that the idea to move to something that's less frequent dosing is, raises some concerns about ethical reasons.
So this is a question about ventral gluteal versus dorsal gluteal. Yeah. Front, back, we seem to be into this front back thing going
front
on.
Back holes, yeah. So the ventral gluteal is just a location. So we actually at our clinic, we do all our syphilis and ceftriaxone injections in the ventral gluteal. There are fewer anatomic structures that you can hit in that location, so that's why it's a preferred location. It sort of feels like it's on the hip, so patients are generally lying on their side. It does take a little bit of training, so we had to train all of our nurses at Ward 86 to give this injection. Dorsal gluteal, if you go in the lateral aspect, is an alternative location. And I think for individuals who have fillers, actually, I've gone I've gone sort of more medial in the dorsal gluteal location, which is at higher risk for hitting a nerve. But it was someone who really wanted to be on CAB-LA. So that was the assessment that we made. That was the safest path to go because they didn't have fillers there. So ventral gluteal is preferred. Dorsal gluteal is an alternative. Ventral gluteal does take a little bit of training, but it's not hard to do. And that's generally where we do all of our injections.
And thigh injection coming, or?
I think that it's not on the label, so I think we've been a little bit hesitant to step into that. And we've had conversations with ViiV, and they haven't really suggested it either. So I think it's coming, because I think the PK suggests that it should work fine.
Right.
I think that the tolerability might be a reason not to do it. So, I think we'll see. I think there are some providers who are doing thigh injections, and I think it's okay.
And so lenacapavir likely to be approved, we would guess, sometime in 2025.
Yeah.
And do you know anything yet about commercial availability of lenacapavir resistance assays? I haven't heard anything yet.
That's a good question. I don't know if that's if Monogram is able to assess that yet. But
I mean, it's basically a sequence for the genotype, and we would know the resistance. I would expect it would be following. Yeah.
Because it's being used for treatment as well. So so I think there's a reason for it to be added. It's not something that should be difficult.
Right. Can you comment on co-administration of IM PrEP and IM Suboxone? In other words, okay in the same buttock or switch sides? Or?
So I think for CAB, unlike with Cabenuva where you're sort of taking up both cheeks, you do have a free cheek with Apretude, so you can go in the opposite cheek. I generally try to spread the love across both cheeks if you can. So you can do it in both sides if you want to, if you have to. If it's Cabenuva, I'd probably do it on the cabotegravir side because ropivarin usually hurts more. But I wouldn't go on the same side unless you have a reason to.
So this is a case where you really can turn the other cheek.
Yeah.
Couldn't resist. It was right there. I couldn't pass. It was too easy.
I think Carolyn has a comment about this too.
Okay.
Sub-Q, yeah. Okay.
Yeah. How do you get Truvada for uninsured individuals, what are the resources? In other words, I don't know if there's any kind of patient assistance for that.
Yeah, so Truvada has been covered historically by the Gilead Advancing Access Program, which they recently notified that they were going to be ending. Appropriately, there was community outcry and backlash around that, so they walked that back. I think that it eventually will be a business decision that they make unless they're forced to not make that decision. So I think we need to continue advocating for availability of that given some of the gaps that it's going to create in our access. So advancing access has been a really tried and true. I think it's available as generic now. So it's about $30 for a pill, for a bottle if you can get it through a pharmacy that has access to generic. So sometimes we actually go through that and patients are able to pay for it. That's also an option.
What do you do if you suspect a false positive NAT? How do you work that up further? It might be somebody maybe with, I don't know if Levi would make sense there, but just the general long-term follow-up. How do you decide when there's been a, sure enough, as we say in the South, breakthrough?
Yeah. And so if someone has a positive NAT, I think my suspicion for HIV diagnosis is much higher than a positive antibody antigen. And so if they have a positive NAT, particularly if they've been on long-acting, we would do a individual viral load, and then we actually would try to get a single copy testing done with the seroprep team. But generally, I have a conversation with people, and I think most folks feel when this has happened, like, we have this ambiguity in whether or not this is a true HIV diagnosis. And when this has happened, I think we've had 3 or 4 cases of this. Folks have gone on to antiretroviral therapy, and we've just sort of continued it. And they've been enrolled in some studies where they've done like analytic treatment interruptions, but the risk to their health and potentially to their partners were all considerations that they had in making that decision to start ART.
This is interesting, sort of thoughtful in a way. What do you have somebody who's got some chronic renal insufficiency and they want PrEP, they can't get, say, the cabotegravir, and you want to give them 211. I mean, I guess you would use Descovy there, or TAF-based, or
so we don't have data that TAF. So when 211 has been used for TDF-FTC, it has not been used for TAF-FTC. The PK suggests that it should, the half-life is actually longer, so it should work fine. But we have no clinical data. The data that came out from the IPERGAY study, which evaluated 211, did show that there was smaller decreases in creatinine clearance, and but if someone is got a creatinine clearance less than 60, they probably shouldn't be getting TDF-FTC at all. So TAF-FTC as 211, you could consider. It's something that I think I've done once because that was all that we had, and I'd rather them have some access to prevention than no access to prevention. But it's something that come with a lot of counseling and all the caveats for why we don't have any data to support that.
Yeah, great. Well, there's more questions because there's a whole lot of interest in this, but we've run out of time. Outstanding. Thank you so much, Hyman.